Hi, it's Michael Altos recording the Cardiovascular System, Lecture 1, which talks about vasodilators and antihypertensives, and we're in Part 3 of that lecture here. So now we're going to move on to a different class of drugs. These are drugs that you won't be giving people, but rather your patients are going to come in to the pre-op area, to the perioperative period, already taking these drugs. The first thing we need to do is review a little bit of physiology. We're going to talk about the renin-angiotensin-aldosterone pathway, which involves a surprisingly large number of different organs. It all starts in the liver, which creates a proenzyme, a precursor enzyme called angiotensinogen. And that is converted into angiotensin 1, and that happens due to the effect of renin, and that's secreted by the kidneys. So already we have two organs at play here. And angiotensin 1 converts to angiotensin 2 by means of an enzyme called angiotensin-converting enzyme, or ACE. That substance is secreted from the lungs. Now, angiotensin 2 already has a lot of vasoactive properties. It causes vasoconstriction. It also causes your body to retain sodium and water. But that's not all, because angiotensin 2 then goes to the adrenal glands and stimulates the adrenal glands to release aldosterone, which is a hormone that also causes retention of sodium and water. So with this little map, we can talk about drugs that work at different points in this pathway, and these are common drugs that we see patients taking all the time. First, we're going to talk about ACE inhibitors. ACE inhibitors have become the first-line therapy for systemic hypertension in many patients, especially in patients who have some degree of congestive heart failure. ACE inhibitors have been shown to reverse the hypertrophy of the left ventricle that occurs in the setting of chronic hypertension. There have been improved outcomes in diabetic patients, and as we saw just a moment ago, when ACE is blocked over here, then we have less angiotensin, we have less aldosterone, and ultimately we have decreased water and sodium retention. So patients become a little bit volume depleted, which also helps with their elevated blood pressure. There are a lot of ACE inhibitors out there. I've put several of them up here just to familiarize you with their names. They all end in pril: enalapril, quinapril, ramipril, lisinopril. Lisinopril is probably the most common one that you hear about. And here are the brand names as well. One of the common side effects is cough and other allergic-like symptoms. I don't know if that's due to accumulation of bradykinins. I'm not sure if maybe it has something to do with the fact that angiotensin converting enzyme is secreted in the lungs, but this is a common side effect. But nevertheless, these are desirable drugs because a lot of the other side effects we see with antihypertensives are absent in ACE inhibitors. Now, even though we said that they're such good drugs, we do see some decreased glomerular filtration in the renal in patients who have renal disease. So this drug has to be dosed carefully in renal patients. We also have to be careful about hyperkalemia. Most of the antihypertensive drugs, and we'll see this in a couple weeks, drop your potassium levels, but ACE inhibitors actually increase potassium levels, and that's because when you save sodium, you pee out potassium. We're going to talk about that more in a little bit. There's also a common allergy from ACE inhibitors, which is angioedema. That's pretty severe, and patients will tell you right away if they've had angioedema due to ACE inhibitors. Here's a picture of angioedema. This is angioedema of the lip. Here's angioedema of the whole face, including the lips. This could be due to an ACE inhibitor, or it could just be a regular old anaphylactic reaction. And this is very classic angioedema of the tongue. You can imagine being called as an anesthesia provider to provide airway management and perhaps have to intubate this patient. These patients really do have their tongues sticking out of their mouth like that. It can be an airway emergency, and it can last for several days due to ACE inhibitor angioedema. There's another interesting issue with ACE inhibitors and general anesthesia. We've seen some pretty severe prolonged hypotension in patients who are taking ACE inhibitors. For that reason, a lot of people like to hold ACE inhibitors for 24 hours or even more before surgery. And these patients can become what's called vasoplegic, where they don't actually respond normally to fluid boluses and phenylephrine boluses or even levophed boluses and infusions. They become very hypotensive. And vasopressin is often the drug of choice. Sometimes they'll even give them methylene blue. Now, my personal opinion on this matter is you see this mostly in cardiac surgery and other very serious major surgeries, and I think it's probably a little bit less of an issue in patients having routine elective surgery, joint surgery, and other general surgery type procedures. But we do see patients on ACE inhibitors becoming more hypotensive in the operating room, and it's only a subset that really develop this vasoplegic syndrome. Now, we've talked about ACE inhibitors, which block angiotensin converting enzyme. Now, if you don't block ACE, then you develop angiotensin 2, and we can block the receptor for angiotensin 2 with angiotensin 2 receptor blockers. So they act just a little bit later in the same pathway. The most common drug is losartan, which is called Kozar. It kind of sounds like the name of a Viking deity, but it's really a very common angiotensin 2 receptor blocker, which inhibits the effect of angiotensin 2. And we saw that angiotensin 2 directly causes vasoconstriction, so this drug reverses that. It has a lot less incidence of that cough that people develop with the ACE inhibitors, but we do still see hyperkalemia, especially when it's used in combination with some of the other potassium-sparing diuretics. The drug is metabolized in the liver, and pretty much clinically it acts a lot like the other ACE inhibitors. And some people suggest discontinuing these drugs also prior to major surgery. And here's that map again, showing where some of our drugs work. So here we have ACE inhibitors acting at this point, preventing the formation of angiotensin 2. Here we have angiotensin 2 receptor blockers, which prevent angiotensin 2 from making aldosterone secrete. And then I guess maybe this arrow should really be up here because they block angiotensin 2 from having effects directly on the vasoconstriction as well. That's it for this lecture. Please let me know if you have any questions, and we'll look forward to seeing you in class.